Today I'm going to show you how to build in real time a Class 2 Division 2 case. This particular case is a severe case and the request is not to move the maxillary teeth at all. The patient's main complaint is the severe curve of spee and the mandibular crowding. I'm Dr. Petra van der Merwe, an orthodontist with 30 years private practice experience. I help dentists avoid common aligner mistakes and design predictable treatment plans for their patients. Today I'm looking at a Class 2, a severe Class 2 Division 2, massive overbite. Deep curve of spee, maybe more visible from the front. And then, left-hand side would be just the same. Overjet of, let's see, from the incisal to the incisal, that is 7.5 to 8 millimeters of overjet in this patient. The patient's complaint is the crowding of the mandibular incisors. She loves the upper teeth, and maybe I should take you through the clinical records. And looking at this picture, a beautiful woman, upper teeth beautiful. For us, looking at it, visible a cant with the right-hand side lower than the upper left-hand side. She's not even aware of that, and I'm not going to bring it to her attention. The bottom teeth, the problem, and especially that one being dark, makes it even worse, the irregularity of the teeth there. We'll get back to the deep curve and treating that. Profile-wise, the nose-lip relationship is really in a good position. The upper teeth supporting the upper lip, and the overjet, strangely enough, with a massive, how big it is, not really something that catch my eye. 3 crowns there, teeth that can do well with bleaching, color, getting the brown colors out, and this non-vital tooth very obviously in the this discoloration really drawing the attention to it. So let's go back to the case itself. Patient's request is the patient's main complaint is, I don't like my bottom teeth, I want them straight. The dentist added, because of the crowns and them, let's just maybe have a look at the lips, having posts in them, and the risk of moving them around, putting force on them, the dentist requested no movement on the upper teeth. So it's quite a challenge to straighten out the bottom teeth, not to move the upper teeth. The reason why I say that is if we go back to the photographs, we need room. Firstly, if looking at this and you see the gums there, the biotype, stretched out, thin, not really room for inclination. That tooth already is on the edge, almost through into the, out of the attached gingiva, very little attached gingiva here. There may be a little bit, and then on the sides, if we go out buccally, we have to go out buccally as well at the top, creating space, and the dentists don't want movement at the top. So it is a challenge. How are we going to address this? Going back there, secondly, all of us know that to create space or to intrude, to get rid of a curve of spee, you really need space. So a lot of crowding and extra space needed to alleviate the crowding. One thing is to do interproximal stripping, looking at the premolars, never ever in the front. My rule of thumb is not to strip interproximally in the front, because when we need the space is now, and you cannot get an interproximal strip through there to reduce. You're going to do it at an angle, and that always shows afterwards. I've seen so many a case of patients who had interproximal stripping done, and it's uneven, it creates gaps at the top, or the angle is wrong, and it's visibly afterwards. And the patients are upset by that, and you can't close that gaps again. So if I do interproximal stripping, I always do it at the on the posterior teeth, looking at her, then I judge, and oftentimes your 4s, you can see the width of this 4 is more than your 5. This side maybe a little bit less. This one is squeezed from buccal to lingual, smaller, and this one is wide, but again, measure distally, maybe a lot of room there to do interproximal stripping. So in a case like this, I would just check practically how much space do I need to intrude. And let's see what happens here. I'm just going to take those teeth back there. What is important to understand as well is if you move the teeth and you take them to a new position, you don't want to create instability. This patient currently has got a stable occlusion. I'm looking at the TM joint. I haven't seen the patient myself, but the dentist told me that there is no TM joint signs or symptoms present in the way that she conveyed it to him. She's got healthy periodontia, maintainable healthy. There's no abnormal or high levels of tooth loss on the occlusal or the incisal edges. Little for her age, it's correlate, but there's not excessive wear on the teeth. And then the last sign of a stable occlusion is any movement on the teeth. Are their teeth moving? Now again, out of the history taken from the patient, there's been movement, but it's been very slowly over years. It's not a swift movement in the last period of time. So I would classify this patient to have a stable occlusion. Once you start moving teeth, you have to understand, if you take them out of a stable position and you don't create whatever is needed in that position for stability again, they're going to move again. So looking on the screen here, and you look at the occlusal contacts, she's got contact literally on all the teeth. So if I'm going to intrude those bottom incisors, I'm going to take the stability away. They're not going to be in contact with the upper teeth anymore. So what is going to prevent them from over-erupting again? It's always important to ask yourself that question. You need to put the teeth in a stable position. And this is not doing it. But let's see how we can address that once we're done. Just back to that point, when I decide on the retention protocol for my patient, I don't have a generic retention protocol. Once I've completed the whole treatment plan, then I decide, determining on the stability, on whatever I've done there, what type of retention I need. So let's go back to the case and to the mandibular incisors. We want to intrude. One always sees this in a class 2. There is no contact, so the mandibular incisors over-erupt till they make contact somewhere. Okay, now I don't want to give her an open bite, so we just have to check how much we're going to intrude for her there. And going back to the pictures, this is an aesthetic treatment. She's got a bit of a curve. She's got a lot of other factors. So I think if we use a canine there as a level, maybe intrude slightly on that one, get it into that line, she's going to be very happy. We will present it to her. So let's just see. I didn't move that canine. Let's use that as our reference tooth in terms of height that we want to achieve. So that would be max that I would intrude. Now already we can start seeing the amount of space that I need just by intrusion. Now we need to get some sort of alignment. Looking at the teeth, again, for stability, you want the teeth in the trough of bone. If you, actually not for stability, more for the periodontal health, bone health, and for stability in the sense of occlusal forces. If you push these teeth forward, the angulation may become such that the teeth aren't going to be stable. They're going to relapse. They can either splay if you've put them too far forward, or they just are going to go back because of the force application on them. So my aim is always to try and see, can I stay in that trough or that line where they've been? So now I'm going to choose myself a tooth, a reference point, and I like that one. That's maybe slightly forward. That in terms of position is maybe better, but that's going to be a hard one. And then I'm going to actually increase the overjet massively. And this patient at this stage is not aware of the overjet. She's not complaining of it. But if you increase it and the lip catch behind it, be aware, she may come back and then she wants to be retreated, or she's not a happy patient and is not happy for your practice. So never increase an overbite. The patients don't like that. Actually, it's an overjet, not an overbite. So let's see. If we use the 4-1 as our tooth of reference and we want to get all the other teeth in line there, let's see. There we are. We would like to have a little bit of a better root inclination there. There we go. And there we go. That one showing a lot of labial surface. Let's see. And now we've got it starting to get an idea of how much space we actually need. So let's just consolidate that and see where was the midline. The tooth is in the midline, so let's take the calculator and add it all up and also see what's going on. Let's just get the inclinations correct. That also changed our space. Let's just, for aesthetic reasons, keep the midlines lined up. Something else that you have to be aware of, so important, dark triangles. Teeth that are overlapping impinges the periodontium. Once you start unraveling that, the periodontium doesn't always go back into that space and the pupil doesn't reconstruct. And that's something else that makes a patient so unhappy. So be aware of what's happening with the periodontium. How healthy is it? What is going to happen with that? So let's just go back to the midline here. This is just blowing up, starts looking like a dark triangle, which I wouldn't like to have. So let's just, and there we go, that's so much better. When I look at the teeth, sometimes the incisal edges make your eyes fool yourself in terms of the teeth and the long axis of them. So what I do is I take the model and I'll move it up and I'll obscure the incisal edges, not to have my eyes tricking me. And then I'll look at the contact points there and make sure, because if I do that, I get that dark triangle, and now I can see this tooth is not lining up with that one. So let's just go back there. No, I don't like that. That triangle bugs me. Just close that up, that space there. That's maybe not Now, I'm doing detail. It shouldn't be done now. Let's just carry on to see how we're going to address the space problem here. How much space do we need? That tooth needs to be uprighted, so let's just get it in 1.2 on this side, and on this side, let's just oh, come on. Yeah, I need to, sorry. Here we go. So 1.4, 1.2. 1.4 stripping. If we go between the 6 and the 5, 5 and the 4, 4 and the 3, and we do 0.5, 0.5, 0.5, that's a lot. That's really a lot. 4, 4, 4 would be 1.2, then we're still not there. And on this side, 4, 4, 4. So yeah, that starts becoming a possibility, is to do interproximal stripping medial between the 6, 5, 4 and the 3, and that side as well. What I do find is that once we start doing that, then we end up also with a Bolton discrepancy. And I need to see, can I land in a vertical dimension with my palatal cusp in a fossa or in the depth of a tooth? It doesn't help I end up on a sliding or inclination. The tooth is going to slide going towards that side, and it's going to open up spaces. So by stripping, removing that amount of enamel, we are creating a Bolton discrepancy. Maybe we can play with it. Maybe it can work out, but maybe not. So that would be my next choice, to go and see how much can we work with that amount. I just don't like what's going on there. Okay, so let's start doing that. Now I've established I'm going to work on interproximal stripping at the back. There are other choices we can do as well and see how it works out, but that's now our first choice. Oh, come on. $1.4 and this side. Okay. Okay. 1.5, let's just go for a 0.4 and a 0.4 and 0.4. And I actually still have some 0.36, which is too much. 0.5 is way too much. It is impossible to reshape the tooth. And once you strip more than that, you are really impinging on the papillae, on the periodontal health. You're not creating room for that, and you're going to get periodontal disease. The periodontium may start moving down because of the impingement and the interradicular bone that's compressed there. So that is not healthy. Yeah. So this really, when I would do something like that, is if we've got crowns, one would start to, I'm not happy with this. I don't feel comfortable. Where does this come from? There shouldn't be. Okay, so that is that one there, 0.4. Yeah. 0.48, this is way too much. Yeah. Let's see if we can maybe go slightly forward. I already did go forward there. This tooth, if I remember correctly, one of these, this one has got a recession on. Let's just double check that. No, not really. So that tooth position, the 3-1 is not bad. That's the 3-1, but looking at that, I kept that position intact, so I'm happy with that, I'm happy with that, I'm happy with that. Good, but this interproximal stripping is really, really a lot. Now, the point is, let's say, for instance, a dentist says he wants to do that amount of stripping. Where do we end up with our teeth, with the upper teeth hitting there? And to determine that, let's have a look at the upper jaw. Contact points and original. And what we have now. Interestingly, on this side, it haven't changed much. That's weird. On the patient's left-hand side. Oh, I didn't move the teeth, that's why. Patient left and bottom. I need to move them. Let's just do that quickly for the sake of the illustrating my point. Okay, let's see now. That's what we've got with the contact points. For this patient, it is stable. You can see each and every tooth has got a contact. They're very similar in the amount, in the force level. And how are we going to change that? Let's go to the final. There we're creating hard contacts. Let's just compare. The molars pretty much the same. The problem are the bottom, the premolars. Yeah, it may work. Let's see from the inside. Remove the contacts and let's see what we have. So we're doing something there. Right there, let's see. And that is a hard contact there. And yeah, so the whole of the distal area of the 5 there is going to be really in a hard contact. The patient may complain about that, as well as the cusp point there. Let's have a look at the five, between the 4 and the 5 in the bottom. Again, red, hard. Also, and there, that canine there is definitely a problem. The mesial aspect of the fore hitting on the canine, that's going to cause trouble. If a patient's occlusion is stable, if the joint is stable, she's balancing everything that she's got there with this massive class 2, with not having contact in the, well, not proper contact. She's got contact for stability. But functionally, if you change the system, she may start grinding. I've seen so many patients, and I don't say this is what's going to happen with her, but I've seen so many patients with proclined maxillary incisors. And if they've got an irritation and they start working that irritation away, that premature or that hard contact, then they start splaying the front teeth. So I'm just very, very wary of changing anything in a patient's bite. If I expand, I will always see what type of contacts I had before, how hard were they, and I'll recreate that in the expanded position. Here now we're only doing mandibular stripping, and we're creating a Bolton discrepancy with a lot of unnecessary hard contacts. If the dentist is good and he can go about and do equilibration, I can't tell him. There we've got a bit of wear on that canine tip there. So he's going to have to reshape there, which won't be too bad in terms of giving it the canine look again. That's a very hard contact. He's going to have to slim the tooth off there. And the same on this side with this canine. I think that's going to be most of the stripping or the reshaping of the teeth needed. And then the contact points there, equilibrated. Supposed to be the same at the top.